Um, and this is our 6th year of running this regional conference. And I am pleased to say that in addition to covering a broad range of topics from hypersomnia to pediatric sleep health to wearables and sleep disorder breathing, we've had over 3,000 attendees in the years that we've had this session. And I have to tell you that we boast one of the highest attended CME conferences at Yale. And so thanks for making it so, and we appreciate our wonderful speakers. Today I was going to introduce Dr. Daniel Buysse. And it's a real pleasure to introduce Dan, who is a endowed chair of sleep medicine at University of Pittsburgh Medical Center. He is also a professor of psychiatry and clinical and translational science at University of Pittsburgh Medical Center. He received his medical degree from University of Michigan and then did his residency and fellowship training at University of Pittsburgh. He is a well-established and innovative researcher. His focus is on assessing pathophysiology and treatment of insomnia, interactions between sleep and circadian rhythms, behavioral interventions for sleep, and the impact of sleep on health in general. Dr. Buysse has been a prolific researcher with funding from the National Institutes of Mental Health, the Institute on Aging, the Heart, Lung, and Blood Institute, and the National Center for Advancing Translational Science. He is currently on no less than 19 federally funded research projects and has been on over 50 funded research projects in the past. He has published over 400 peer-reviewed articles and over 100 chapters or review articles. He is the PEST president of the American Academy of Sleep Medicine and is currently the president of the Sleep Research Society Board of Directors. He has received many awards, including the Nathaniel Flightman Distinguished Service Award from the AASM, as well as the Mary Garskadden Outstanding Award from the SRS. And so without further ado, I am really honored and pleased to introduce Dan Buysse to give his talk today on sleep health.
Thank you very much, Andre. Really appreciate that kind introduction. And I appreciate the invitation to be here to speak with all of you today. This is the first of two disclosure slides, and I think that you're probably familiar with the information there. What I'd like to talk about today is actually the last thing that Andre mentioned, which is looking at broad relationships between sleep and health and how we might understand those relationships and come to some new forms of researching those topics. I have a couple of slides with unpublished data that I'd prefer no one take screenshots of today, but otherwise everything's good to go. My second disclosure slide is here. And the only thing I want to point out is that I am going to be presenting some preliminary data from an investigator-initiated study that was funded by Sleep Number, and I'll point that out when we get there. What I'd like to do today is to, again, provide this framework for talking about something that we call multidimensional sleep health, MDSH, and I'd like to talk about how we can conceptualize that, how we can measure it and statistically analyze those kind of data, and then look at how we can use multidimensional sleep health to come to a better understanding of sleep's relationship to other health outcomes. Finally, I'll just touch fairly briefly on how we might use this model to develop and conceptualize new interventions, mainly behavioral interventions, to improve sleep and health outcomes. This audience, I think, needs no introduction to the fact that sleep poses risk for things like obesity, diabetes, cancer, heart disease, depression, substance use, and even for early mortality. The importance of sleep is recognized by the American Heart Association, including sleep now as one of life's essential 8 risk factors for cardiovascular disease. It's the most recently added one. So given that in the big picture, we know that sleep is related to health, the question is how is that so? How can we kind of understand that? How can we begin to research that? And what I'm going to do today is kind of pose and juxtapose two concepts. One is that of sleep disorders, and the other is sleep health or multidimensional sleep health. Now, I'm guessing that for most of you, the first thing here, the sleep disorders part, is very familiar. We know that there are 6 major categories of sleep disorders, as described by the AASM's International Classification of Sleep Disorders. And again, there's abundant evidence that each of these disorders is related to poor health outcomes in one way or other. And again, I'm not going to belabor this point because I'm sure that you're all very well aware of this. The question, I think, the interesting question is, what about sleep for people who don't have one of these disorders? If we don't have insomnia and if we don't have sleep apnea, does that mean that sleep is unimportant for our health? And it really, I think that most of us would intuitively understand the answer is no, of course not. But it does raise the question, what is good sleep? What do we mean by good sleep? And this is, I think, a deceptively simple question because sleep means a number of things. We know that sleep can be described as a complex neurobehavioral state that's regulated by well-known brain circuits and brain structures. But we also talk about sleep as a temporally ordered process that unfolds across the night. And we talk about sleep as a state that is both accompanied by and regulated by typical behaviors. So when we talk about sleep, we try to describe in quantitative terms at different times each of these things. So to illustrate what I mean by that, let's consider kind of a cartoon diagram of how sleep exists in the 24-hour day. And in this cartoon, sleep is the blue block that occupies about 1/3 of our 24 hours, and wakefulness in yellow is the rest. Well, we know that we can describe this situation, we can describe aspects of sleep and wakefulness in different ways. For instance, we can describe how satisfying, restful, or how good the quality of our sleep is. And we can have good sleep or we can have poor sleep, satisfaction and quality. Our sleep can result in an ability to maintain sustained alertness during the day, or it may be interrupted by sleepiness and poor alertness. Our sleep timing may be appropriate relative to the biology of the circadian biology of most human beings, but we know that some people have late timing or early timing. Likewise, sleep doesn't occur as a solid block during the night, but can be marked by poor sleep efficiency with frequent awakenings. Our duration can be normal, about 30% of our 24-hour day, or it can be short or long. And finally, sleep can occur at regular times and durations across the week, or we can see considerable variability in each of those. So again, sleep, the normal sleep that we think of at night, can be described along multiple different dimensions. And a variety of research evidence from several decades has shown that each of these dimensions can be related to either poor or good health outcomes in some ways. But I think the real issue here is not that we can describe sleep in multiple ways, we can measure multiple things. The real issue is that our sleep includes all of these things at all times. So an individual may not only have short sleep duration, but they may have poor sleep efficiency and late timing and find that and describe the quality of their sleep as poor. So a person who has poor sleep along multiple dimensions is unlikely to be the same as someone who has poor sleep in only one. This leads to the conceptual framework of multidimensional sleep health, which can be described as follows: a multidimensional pattern of sleep and wakefulness adapted to individual social and environmental demands that promotes physical and mental well-being. So again, another cartoon, we can think of the 6 dimensions that I just talked about. And importantly, we can categorize where someone is, where an individual is on each of these dimensions at any point in time. And it's really the composite, we postulate, the composite of these dimensions that is capable of promoting good health. So the acronym that we often use is that we can describe these, we can kind of call these dimensions RU sated. So just to give you an idea of why these things might be important, consider 3 individuals. The first individual sleeps for 5 hours and is a night shift worker, so sleeps at abnormal and shifting times during the week. The person reports moderate quality and sleep efficiency, but again, the timing is very distinctly different from most people. Next person also sleeps for 5 hours and reports poor quality and low efficiency while sleeping at night, and in fact, has many of the features of insomnia. A third person might also sleep for 5 hours because he or she is working 2 jobs, raising a family, and just doesn't have time for more sleep. As a result, has very good sleep quality and high sleep efficiency, but just limited time to sleep. So if all we measure is 1 dimension at a time, if we just measure the person's sleep duration, we would have to assume that the health risks posed by the sleep patterns are the same for these 3 individuals. And I think you can appreciate that that is very unlikely to be true, that we need to consider sleep in a broader context. There are several benefits, I think, of considering sleep from this multidimensional perspective. It gives us a shared conceptual model. It may enhance replicability and rigor if we consistently measure these dimensions. It may improve and provide different means of health screening. It can accelerate mechanistic research and suggest novel treatment strategies. And I'll be talking about each of these things in turn today. So again, just to go back to this, the kind of 2 conceptual models that we might have, the sleep medicine perspective, which most of us grew up in, focuses on sleep disorders. How do you diagnose people? How do you treat them? And it's really very much a disease model. Medical disorders and diseases are typically categorical. You have them or you don't. And what we're trying to do by identifying and treating sleep disorders is to avoid negative outcomes. On the other hand, the sleep health perspective focuses on sleep characteristics that are present in every individual at every point in time. So the emphasis is on measuring sleep dimensions and on optimizing sleep, which is more consistent with a health promotion perspective. One of the useful things I think about this model is that it applies to everybody at every point in time and is really perhaps more consistent with agendas of improving population health as well. I think it's just important to remember in summary that the absence of a disease does not mean that we have good health, right? The fact that I have not had a myocardial infarction does not mean that I have excellent cardiovascular health. And likewise, the absence of a sleep disorder doesn't imply that a person has great sleep. The other thing to emphasize is that these are not mutually exclusive. I'm not saying that we should not search for and treat sleep disorders. We should. But I think that that may not, in some cases, be enough. I mean, how many of you have had a patient who has sleep apnea, it's identified, it's appropriately treated, and they still have symptoms, right? So I think one way of thinking about that is to go back to Ash and Volpu in describing kind of health, what health and health promotion mean. They pointed out that the healthcare delivery focuses, again, on identifying disorders and providing health care, but what people really want is to be healthy. And I think by analogy, we might say that the current sleep medicine system focuses on sleep testing and diagnosis and disorders, but what people really want is better sleep. And sometimes treating sleep disorders is not enough in itself. So if we believe that multidimensional sleep health is a useful construct, the next question is how we can measure it. the first point I'd like to make here is that the specific dimensions of multidimensional sleep health will vary with different levels of analysis. So if we ask someone to self-report their sleep, we can get all of those dimensions, the regularity, satisfaction, alertness, timing, efficiency, and duration. A sleep diary is one classic example of how to do this. But we can also measure multiple dimensions of sleep with behavioral measures, such as actigraphy. Now, you can't measure satisfaction or self-reported sleep quality, but you can measure everything else in these dimensions with actigraphy. You can also get something different, which is rest activity rhythms. Polysomnography doesn't usually tell us much about a person's regularity or their satisfaction, but it's great for the other dimensions. It also gets further dimensions of sleep stages and sleep architecture, as well as events during sleep, such as sleep apnea. And is very good for describing the temporal process of sleep. And finally, I guess we could imagine a scenario in which things like functional imaging might be more useful ways of categorizing sleep as well. So how we define multiple dimensions of sleep will differ depending on how we measure it. My colleagues and I have been interested in the very simplest of things. And so we devised this questionnaire that's now in version 4. What we tried to do was to represent with a single question each of the 6 dimensions that we think are most important. Each of these is responded to on a 5-point Likert scale with higher scores indicating better sleep health. So again, the scale ranges from 0 to 24. 24 is better sleep health. We've recently completed a validation study that was supported by an investigator-initiated grant from Sleep Number Corporation. And so we did both qualitative and quantitative work. We had a representative sample of 2,000 US adults from the YouGov online sample. And we did some classic statistical analyses, psychometric analyses, showing that we really identified one main factor. Now, some of the dimensions don't load as strongly on the factor analysis as we would typically expect, but fit indicators suggested that a single dimensional model that is measuring overall sleep health fit pretty well. And a scree plot is another way of asking how many dimensions are in this scale that I have. And again, a one-factor solution looked to be the best. We examined some known groups, construct validity, that is, do people with sleep disorders report worse sleep health than people without sleep disorders? And the answer is yes. It was true for if we asked about any sleep disorder or specific sleep disorders as well. People with sleep disorders tend to report worse sleep health. We also, so this is all with questionnaire data, and just to show you that it is possible to measure sleep health in a valid way with self-report data. So you can also use other methods such as actigraphy. And one question that people have is, well, how do we know kind of what's good and bad with regard to any of these dimensions? So in analyses from the MIDAS and MIDAS refresher studies, Ryan Brindle, when he was actually just after he matriculated from Pitt, did these analyses. And using actigraphy data for the dimensions of timing, regularity, efficiency, and duration, Ryan was able to ask, well, what values are associated with the lowest risk of cardiometabolic morbidity? And interestingly, the values that were associated with the best health, the best cardiometabolic health, were pretty much, I think, what we would expect, that a midpoint of our sleep timing between about 2:30 and 3:30 in the morning, regularity, having a standard deviation of less than an hour a week, efficiency of about 85%, and a sleep duration of about 6 to 7 hours by actigraphy, not self-report, that these were associated with the best cardiometabolic health. So again, it is possible to derive kind of cutoff values for what constitutes good and poor sleep health on each of these dimensions. I'd also like to mention that we can think about sleep health in more of a socio-ecological context too. So this is a nice figure from an AHA position statement recently published by Marie-Pierre Saint-Onge and colleagues. And this emphasizes the important point that individual level factors, social level factors, and even societal level factors can all influence these different dimensions of sleep health. And again, the different dimensions of sleep health individually or in composite can affect multiple other areas of important health functioning and perhaps even lifespan. So we've been very interested again in self-report measures of multidimensional sleep health. Other people have come up with other sleep health scales, including the National Sleep Foundation. Their scale has 3 subscales, one for sleep quality, one for sleep duration, and one for disordered sleep. Lisa Meltzer and colleagues have described sleep health for pediatric patients, and they include behavior as one of the key dimensions that we need to assess either. So again, just the point is that there are different ways of measuring multidimensional sleep health. We think the RU Sated scale is one good way, but actigraphy and these other self-report measures are also very helpful. So I'd like to talk a little bit now about how we can analyze these data, and I will illustrate with some examples relating to how sleep health influences other health outcomes. There are challenges in using any kind of multidimensional framework. First is that we have multiple sleep health domains. It seems unlikely that sleep health poses risk as a simple linear combination of dimensions. We also have multiple health outcomes, and it's unlikely that all sleep health dimensions are equally relevant to all health outcomes. But I do think that it's important that we assess these dimensions consistently and that we examine them consistently so that we can map out these relationships better. When we think about how to analyze multidimensional data, we can think of several different approaches. The simplest, of course, is to use a scale such as RU Sated and just tally up the points, just get a composite score for each sleep dimension, a very easy approach. We can use factor analyses or principal components analyses to see which specific sleep measures kind of hang together with each other. And we can do cluster or latent class analyses that help us to understand how different groups of sleep measures cluster together in different individuals. So are there groups of people with similar sleep profiles? And finally, we can also use machine learning and other AI related techniques to identify patterns in data that may be more difficult for human beings to see. So the interpretability, I think, goes in this direction, that it's easy to understand what a composite sleep health score means, whereas the precision of our methods likely is inverse to that. I'd just like to show you a couple examples of how we can use these different approaches. First, just using the composite approach. These are data from the National Health and Nutrition Examination Survey, cross-sectional data, looking at multidimensional sleep health in relation to cardiovascular, cardiometabolic health outcomes. And what you see here is that those with moderate to poor sleep health versus ideal sleep health, that those with good sleep health had reduced odds of all these cardiometabolic outcomes. Again, cross-sectional data, but again, good sleep health associated with lower risk of cardiometabolic morbidity. In a longitudinal example, this is a one-year prospective cohort study from the Nurses' Health Study. And the question here, rather than cardiometabolic health, was who was likely to develop long COVID. And what we see in this longitudinal study is that with better sleep health, the relative risk of developing long COVID was reduced. We're currently looking at an analysis of multiple studies that have looked at sleep health outcomes in relation to various longitudinal health outcomes. I'm showing here the different dimensions of sleep and a composite score. And green just indicates that there is an association longitudinally with one or more health outcomes. Red means there is not, and yellow indicates a mixed result. And what I want to emphasize here is that in these analyses, the composite, that is considering all of the dimensions of sleep health simultaneously, yielded more consistent relationships with health outcomes than any of the individual sleep dimensions. So it's not just enough to know about duration. If you really want to know how sleep is related to health, you need to consider multiple dimensions simultaneously. I also like this study from my colleague Meredith Wallace, who examined data from the Mr. Ross and SOFT studies to see basically which aspects of actigraphy hang together. And to our pleasure, actually, the actigraphy measures sorted themselves nicely into the hypothesized sleep domain. So we found that there were a group of actigraphy measures that really related to timing, another to efficiency, another to duration, another to alertness, sleepiness, and yet another to regularity. In bold here are the items that most strongly represented each dimension. So it seems that the multiple dimensions of sleep health are not just kind of things that we made up. They can actually be empirically derived from data as well. So we know that the population is heterogeneous with respect to everything. So if we measure several different sleep dimensions in individuals within the population, we can use clustering models or latent class models to identify groups of individuals who are relatively more homogeneous on a collection of sleep measures. So these kind of analyses too have proved to be informative. These are some unpublished data so far from our project working with Sleep Number data. And what we found is that we first of all had a sample of 2,000 representative adults in the US from YouGov. And if we clustered their different sleep dimensions from the RU-sated scale, we found 4 classes of individuals. And when we looked at a separate sample, a convenience sample of US adults who happened to have Sleep Number beds, 3,000 people in these analyses, we saw 4 fairly similar clusters. So the red cluster represents good sleepers. They report good sleep health on each dimension. The blue are poor sleepers. They have the worst sleep on all of the dimensions. And then we saw people who reported poor quality, but were actually fair sleepers in terms of the other dimensions. And conversely, people who reported good sleep quality, but didn't have the greatest sleep compared to the other groups. So the poor sleepers here may represent individuals who have insomnia with short sleep duration. The poor quality fair sleepers, perhaps insomnia with normal sleep duration. And the good quality fair sleepers may be people who are just more flexible in terms of their sleep habits. They can tolerate not having very long or very efficient sleep, and they still find that it results in good quality. So do these clustering analyses, do these classes mean anything, though? In these data from Mr. Ross and SOF, we identified here 3 profiles of individuals. These were older adults. We found one group that had high sleep propensity as indicated by having long nighttime sleep as well as high sleep efficiency and high daytime sleepiness. The average sleep group is in red, and then we found another group that seemed to have insomnia with short sleep. So the interesting thing is that when we looked at mortality data, the phenotype, that is the cluster, was a significant predictor of mortality, whereas a simple sum of the sleep health scores or individual items were not associated with mortality. And in these particular analyses, it was the high sleep propensity group that had the shortest, that had the highest mortality risk. So I'm now treading on thin ice, but I'd like to show you some data from Goodman and colleagues. Haiming Wang from Mass General made me aware of this study. So this is a GWAS study in multidimensional sleep health in the UK Biobank, and goes to the question of, does consideration of multidimensional sleep health help us to develop new ways of conceptualizing sleep and perhaps new ways of understanding biological measures and determinants of sleep. So in these studies, they had both self-report and actigraphy data, and they did principal components analyses that came up with 5 basic components. You can see them described here. The interesting thing to me is that they looked at the heritability of these different profiles, as it were, and compared it to the heritability of the composite. And you can see that some of the profiles had high heritability, particularly PC3, which is interesting because this one is driven very strongly by morning chronotype, which we know is genetically regulated. But PC1, as well as the composite score for just simply kind of adding up the person's sleep dimensions, also showed significant heritability. Now, interestingly, when they looked at specific loci associated with their GWAS, the significant loci they identified were enriched in both multiple brain tissues and in metabolic and neural pathways. So suggesting that, again, these different components representing collections of sleep measures, that they identified novel loci associated with metabolic pathways. Again, suggesting that considering sleep in a more complex way can actually lead us to new insights regarding the biology of sleep and health. So without going into further detail, I'll just say that multidimensional sleep health has been examined in all sorts of health outcomes, representing mental health, physical health, and cognitive health outcomes, with many positive findings, not across the board, but again, I showed you earlier an example of how kind of composite sleep health measures seem to be more strongly related to these sorts of outcomes than any single dimension of sleep. The last thing I'd like to touch on briefly today is how we might use this kind of concept to devise or conceptualize interventions targeting multidimensional sleep health and perhaps health more broadly. The first example I'd like to bring is a new behavioral and cognitive intervention called the Transdiagnostic Sleep and Circadian Intervention, or TSC. This was developed by Allison Harvey, and we wrote a book describing the approach using this kind of treatment. The basic notion of TSC is that, unlike treatments like CBT for insomnia, this approach, we think, is flexible enough to accommodate people who have different combinations of sleep health problems. So one person may have kind of straight insomnia. This treatment can be used for them. Other people may have, say, delayed sleep timing and poor sleep efficiency. This intervention can be useful for them. Other people may have difficulty with daytime functioning related to sleep problems. Again, there's something in this treatment for them as well. The intervention includes cross-cutting modules, including a heavy emphasis on sleep and circadian education. There are core modules that talk about sleep regularity and daytime alertness and how to manage that. There are other modules that talk about improving sleep efficiency and kind of balanced against the total amount of sleep that a person gets. Modules for reducing time in bed if that's needed for sleep efficiency, and some basic behavioral techniques for dealing with delayed or advanced circadian rhythms. So really adopting this multidimensional sleep health conceptualization and devising behavioral interventions that can help with these dimensions. The first test of TSC in community adults was in those who had chronic mental illness. So in 121 adults, they were randomized to TSC or usual care with delayed treatment. And the outcomes were as follows. Red equals the TSC group, and white is the usual care control. And so on measures of disability, on cross-cutting psychiatric symptoms, and sleep disturbance and sleep-related impairment. On each of these outcomes, the TSC group had fewer symptoms at the end of treatment than the usual care group. So again, it's kind of nice to see that this kind of flexible treatment can be employed in real life settings, and that it affects more than just sleep. It affects psychiatric symptoms, and it affects disabilities ratings as well. There are many other studies now using TSC in a variety of adults and adolescents with various kinds of health problems. The next step I'd like to think about is to think, is there an even broader way of conceptualizing this? That is, can we move from thinking about multidimensional sleep health to multidimensional sleep and circadian health, and what might that look like? So we all know that the circadian timing system is regulated by a master clock in the suprachiasmatic nucleus, but the molecular machinery for circadian rhythms exists in every nucleated cell in our bodies. There are clocks everywhere. And so the SCN really has the job of organizing the clocks throughout our brain and throughout our body. Those clocks regulate our neurophysiology, they regulate our systemic physiology, and our physiology drives our physical function, behavior, and performance, including all of the key health behaviors that we now know we need to pay attention to, most of which are represented in the AHA's Life Essential 8. And we also know that those key health behaviors feed back to the biological clock. Now, we're all aware that there are individual interventions that target each of these key health behaviors. But what I'd like to think about is not whether we can treat each of these health behaviors, but if we can go upstream and treat them all at once. Is there some kind of unifying principle that would allow us to have a big impact on people's health behaviors using a similar conceptual framework? And I think that one way that we might look at it is this, that we have a circadian timing system that drives these key health behaviors. They affect our physiology in known ways through important pathways, including inflammatory and immune pathways. And those pathways influence our physical, mental, and cognitive health outcomes. We have to keep in mind that all of this is influenced by genes, environment, and social determinants of health. And the question and the challenge for us, I think, is can we use our timing of the circadian timing system to change all of those health behaviors with a common kind of rubric, acting through these physiological mechanisms to optimize our health outcomes? Now, again, interventions typically aim at one of these things together, but if we know that they're all driven by the circadian timing system, can we move our interventions upstream by one level and have a circadian-based intervention that targets all of the key health behaviors at once? And if so, what might that look like? So if we have our key health behaviors here, are there common principles derived from knowledge of circadian rhythms that we could apply to each of these? And as I think about the multidimensional sleep health framework, to me, the components that are most amenable to behavioral intervention are the amount of sleep that we get, and more appropriately, the amount of time in bed that we spend, which affects duration and efficiency. And we can behaviorally manipulate regularity of sleep, and we can behaviorally manipulate timing. So the amount of time in bed, the regularity, and the timing. But I think that actually the amount, regularity, and timing apply to each of those health behaviors. So we know, for instance, that the amount of light that we get, the regularity with which we get light, and the timing with which we get that light is all important for circadian health. We know that the amount, regularity, and timing of eating, of physical activity, all of these things are necessary to promote health. And each of these things influences the other, and they influence the biological clock in turn. So again, I think what is an interesting way to think about going from multidimensional sleep health to multidimensional sleep and circadian health is to apply this kind of ART framework. And we can kind of sketch out what this might look like. We know approximately what the right amount of sleep and light and dark and physical activity is, a little bit harder to say with eating. We know that regularity is a good thing for all of these health behaviors. And we know that there are timing aspects to all of them as well. So again, it's interesting to imagine using our knowledge of the biological clock to influence not only sleep, but all these other health behaviors. And indeed, several of my colleagues at the University of Pittsburgh have studies going on that are doing this. Sarah Stahl is working with older adults with depression, emphasizing in her intervention a regular routine of sleep, meals, and physical activity. Marquise Hawkins is kind of combining elements of the TSC, multidimensional sleep health intervention, together with elements of the diabetes prevention program to try to turn the corner on postpartum weight retention and sleep disturbances. And Rachel Kalko-Conlon is again doing something similar, trying to affect each of these four key health behaviors in postpartum women, looking at the effect on their cardiometabolic health, as well as on the sleep and metabolic health of their infants. So finally, if we think whether we're thinking about multidimensional sleep health interventions or sleep and circadian interventions, just want to again emphasize the socio-ecological model that we can think of intervening at the individual level, but we can also think about tailoring those interventions so that they are more effectively deployed in specific groups of individuals. We can think about the broader context, like family and group-based interventions. We can think of community or even societal interventions, which largely relate to public policy. So again, if you think that this is all just a pipe dream, think about school start times, right? What does changing school start times do? It affects the timing of adolescent sleep. It affects the amount of sleep that they get, and it affects the regularity of sleep that they get by decreasing weekday differences, right? And we know that it has benefits for cognitive, mental health, and physical health outcomes too. So it's not perhaps as far-fetched as it might seem. With that, I would like to just recap. I think that we can define and measure sleep health. We have statistical tools to help us analyze it. We've seen that multidimensional sleep health does, in fact, relate to other important health outcomes across multiple domains, cross-sectionally, longitudinally, in different ages. And although I didn't present data specifically on this with magnitude comparable to that of other important health risk factors. And finally, I think that behavioral interventions hold the potential to improve sleep and circadian outcomes as well as broader health outcomes. I'd really like to thank all of my colleagues and collaborators at the University of Pittsburgh, particularly Meredith Wallace, who is really a driving force behind the empirical research, much of which I've shown today. We have colleagues in various other locations within the United States and across the pond as well. Again, thanks to my many colleagues who have collaborated with me on this work, and thanks to all of you for your attention.
Wow, thank you so much, Dan, for this wonderful presentation. It's really fun to think of the different approach to sleep health and focusing on sleep disorders that we oftentimes do. And so we have several questions in the chat, and maybe what I'll do is I'll just invite some of our folks to unmute themselves and ask questions. So Clara, I'll start with you since you have some general questions and some more specific ones to start with. Go ahead.
Sure. Can you hear me okay?
Yeah.
Yes.
Hi, Dan, thank you so much.
Yeah.
taking the time to present. This is excellent and really an amazing body of work, and all that you've done to advocate for our field over the years. I had two questions. One is more a clinical question related to, I guess in particular, are you sated, but perhaps the broader measurement of the multidimensional sleep health is. Is it sensitive? How sensitive is it to change? And can it be used in clinical decision making? That's
yeah.
one.
Let me take that one before I get to the second one, because I will forget. I think the issue of sensitivity to change is a very important one, and I just don't know the answer to that yet. The way that I would see that scale in particular is that it's sort of the thermometer of sleep health. And it's enough to let you know if somebody has a fever, but it doesn't tell you, exactly what the cause is. And so if you identify someone who has poor sleep health, you can see which dimensions are driving that, and that can begin a further inquiry. And so other tools like sleep diaries, actigraphy, just a clinical interview, polysomnography, all of those may be important. But the first step is just to kind of get the overall temperature. In terms of sensitivity to change, when we were doing our validation study, we did retest reliability. And honestly, I kind of goofed when I did it, because the time frame that we had for retest was a month, which is also the reporting frame for the questionnaire. And so it was correlated, but actually we were able to see changes just naturalistically without doing anything. We saw changes. A lot of people had a change of a point or two. So that, in an indirect way, leads me to believe that we will see changes with interventions, but I just can't define that at this point.
Right. Thank you very much. The other question is, I think in some of the work our group has done, we have used the construct of sleep deficiency as
right.
forth by the NIH. And I think you've made a compelling case for this, but I wanted to ask the question directly anyway, is do you think, are you sated or other measures of sleep health are measuring a construct of sleep health, or is it measuring the inverse, which is sleep framing?
Yeah, again, that's a really interesting question. And in 2014, in the paper that I published on this concept, I did contrast it a bit with sleep deficiency. Part of it was just an intentional decision to frame sleep health in a positive rather than a negative way. And I think in part because I wanted to get people thinking about, sleep as a positive and something that is necessary for health, rather than something that always goes bad, right? And I do think that sleep deficiency is to a large degree the inverse of sleep health. If you look at some of the first descriptions of sleep efficiency, again, they talk about like poor efficiency and amount and maybe timing. It doesn't align exactly with what I'm talking about, but it's clearly in the same ballpark. So yeah, I think they're certainly related constructs, maybe just mirror images.
Good. Thank you.
Great. Thank you, Claire. Let me see. I'm going to pull up some other ones. You have a question for Dr. Robert Thomas.
Oh, thanks for unmuting me, Andre. So my question is about subjective versus objective. Today, we can certainly measure a lot of objective domains of sleep. Brain waves, autonomic, blood pressure, and so on. Why not combine objective and subjective?
Yeah, fair question. My kind of pat answer is because they don't play well together. So subjective and objective measures, in my experience, tend to be disappointingly related to each other. I think they measure different things, particularly when you get into things like satisfaction or quality. And I know that because we use quantitative measures, even for self-reports of sleep, we would really love for them to align with our objective measures. And they just don't. And there's ways that you can imagine why that is the case. Let's just take one example. Sleep latency. You can ask someone how long it takes to fall asleep. You can measure it with actigraphy, right? Movement at their wrist. You can measure it with sleep. And those three things don't align very well, right? But I think we have the tendency to assume that the objective measure is correct and the self-report is somehow flawed. And I don't know that that's really a good way of looking at it. So we do know that sleep onset is associated with anterograde amnesia, and people are not going to be able to recall, a number of minutes very precisely, but they can certainly discriminate difficulty falling asleep and ease of falling asleep. I think that it's also tempting but mistaken to think that like a single EEG derivation is telling us everything that's going on in the brain. It doesn't. We know that sleep has local variations in intensity, right? So why do we think that one global EEG measure is a good measure of sleep when an individual's self-report is integrating all the information in their brain, right? So my point is not to diss objective measures or self-report measures. It's simply to say they're both valuable categories of information. They have different applications, and I think that we should feel comfortable using them all.
Thanks, Dan. I actually, I have a question for you, if you don't mind. So is there data comparing the sleep health composite score, the RU-SATED score, with, sort of general metrics of wellness, or those that, something like patient global impression scale, or, PGI of change? Because it seems like as you're saying that.
Yeah, not that I know.
Yes,
of,
you're saying that. Yeah.
Yeah, if someone wanted to define the kind of minimal clinically important difference, I think that's exactly the kind of thing that you would do. You would compare it to other accepted metrics and other indicators. So it hasn't been done yet, but I agree that would be a very useful way to go.
And the other question I was going to ask you is, let's assume that it works, and there's some sort of a change of intervention. And how would you envision that this sort of RU-SATED score could be used by clinicians and also commercial providers of sleep health, right? Those who are providing sleep care outside of academic or private institutions.
So I will, again, kind of harken back to my earlier comment. I see something like the RU-SATED scale as being kind of an overall temperature measure. And in that sense, I think that it could be useful in, for instance, an epidemiologic context where the number of questions you ask is, very precious, and you need to get as much information as you can, as efficiently as you can. I think that it could also be useful. I don't know of anyone who's used it for this purpose yet, but I think that it could be useful in terms of clinical screening as well. Again, just as sort of a temperature measure and a preliminary guide to what type of problem a person has. You might contrast that with something like the PROMIS sleep disturbance or sleep-related impairment scales, which offer precise measurements, and they can be efficient. You can get 7 or 8 item versions, but they don't really kind of guide you to which particular aspects of sleep may need some clinical attention. So those are the two best kind of use cases that I can think of so far, is in epidemiologic context and in terms of clinical screening.
Great, thank you. And I think there's a question from Adam Sorter. Let me see if I can identify Adam to unmute him, or let's see. Don't have a functional mic, but my workstation, I'm in the library. Okay. All right, and
I see his
so
name on
I guess
the-
there was a question about, yeah,
Oh,
right.
he doesn't have a
And so
question.
I
Okay.
think Adam
So
was
yeah,
asking
I
about
see the
your
question. I see the
use of.
question in the chat.
great.
Yeah, about cross-cutting modules. So when I was describing the transdiagnostic sleep and circadian intervention, there were modules called core, ones that were called optional, and ones that were called cross-cutting. The ones that are core are the ones that we think, pretty much everybody should have. The optional ones are the ones to use depending on the person's particular constellation of sleep problems. And the cross-cutting modules are ones that you might kind of incorporate elements of kind of throughout each of the sessions. So for instance, the case formulation is basically how you see the problem and where you need to go next. That's something that you're kind of constantly updating and doing at each session. You might sleep and circadian education is something else that you might do that throughout your 4 to 8 sessions with a person. Things like enhancing motivation for change. Again, it kind of cuts across everything else that you do, and that's what we meant by the cross-cutting modules.
Great. Well, Dan, thank you so much for presenting your work. It's fascinating and always lovely to look at things in a positive way rather than thinking about the deficiency. And so thank you for presenting to us. We'd love to have you back at some point in time and join us as well with your group for future sessions. And look forward to seeing your science and see you at future meetings.
Okay, thanks so much again for the invitation.
Take care, everybody.
Fun to be with you all today. Thanks.
Thank
Bye-bye.
you. Bravo.